Anyway, like I said, if there's a chance to meet everyone, that would be great. Good morning to all.
Good morning. I'm not sure I turn on my camera. I don't know how that works.
All right, awesome, no problem.
It keeps on letting me mute or unmute. That's it.
Okay, well, good morning. Glad you're here. All right, I'm just going to go ahead and start by introducing myself. My name is Dr. Ruth Roa Navarrete. I'm an Air Force psychologist. I have been working as an Air Force psychologist since I finished my internship in 2002. And I have been a prescribing psychologist in the Air Force for the last 10 years. I completed my master's in psychopharmacology through Alliant, and my first time teaching actually happened while I was still in the midst of my program, as I co-facilitated the special populations ethnicity class with my supervisor at the time, my clinical practicum supervisor and mentor, Dr. Elaine Foster, who was one of the original psychopharmacology demonstration project psychologists who graduated from the Air Force program several years back. I am a clinician. I am also currently the clinical director of internship training at Wright-Patterson Air Force Base in Ohio. So that's where I am. And in case anybody's wondering, it is pretty cold here. So I might vacillate between, having to turn on my heater and having to turn it off, depending on how it goes. Again, in my role as the training director, I have the opportunity to teach all of the interns a little bit about prescriptive rights and psychopharmacology, and hopefully plant the seed for what may be, hopefully in the future, many more other prescribing psychologists in the military services. I think I saw a question of whether I'm active duty or civilian. I'm active duty. I'm a lieutenant colonel, and I'm eligible for retirement in a year and a half. Don't know yet whether I will or not, I do want to emphasize that all my experience as a prescribing psychologist has been with mostly active duty member, some with their spouses. I don't treat children. I have seen many retirees and their spouses and grown children as well throughout my practice. So some of the case examples that I talk about are going to be pretty specifically focused on military populations, although I think that some of the applicability will be pretty broad. So with that in mind, let me go ahead and share my slides, and we'll go ahead and get started. Actually, before I do that, let me make some housekeeping notes. I want to emphasize that, hold on, pardon me for a moment. I want to emphasize that, can you all see my screen now? And
not yet, Doctor.
Oh, goodness. Okay, let me see how I can make that happen. This may be a little bit more difficult than I thought. I apologize for that.
Doctor, do you see on the same panel, on the same collapsing panel, do you see the share icon?
I do, and it gives me the options to share my screen.
Right.
My photos, iCloud Drive, Box, Dropbox, Google Drive, Microsoft OneDrive, a website, bookmark, or whiteboard.
Right. For just for a simplicity, you can just use the same, the first thing that has been highlighted, the screen, and then on the lower right of the page, just click on the share.
It actually, everything on your screen, including notifications, will be recorded. Okay.
Yeah, that one is for the simplicity. If not, if you already have your PowerPoint on, you can also see your PowerPoint as a one option. In that case, we're gonna only see your PowerPoint regardless of you switch between your pages on your screen.
Okay. I don't know if it's reading it. Let me try something else. I think my computer's come on, so it might be quicker to go that route. And I do apologize to everybody if this isn't, if we're running into technical difficulties, but I guess I'll run into some.
I found the
Oh, good
camera.
morning.
So let's hop in and say hi. I'm Eddie Waldrop.
Hi, nice to meet you.
You as well.
All right, I think I can now log into my computer. So I'm going to try to do that. And while we're doing that, I'll discuss some housekeeping issues. While we're doing the lecture, it may be difficult for me to keep track of the chat box, and we will use the chat box sporadically, especially when I'm asking you questions where I want everybody to provide me some inputs. But during the lecture itself, it's going to be hard for me to keep track of questions that pop up in the chat box. So if you would, please unmute your comments and unmute your microphones if you need to ask a question or if you have a comment, and ask the question by using your microphone as opposed to the chat box. If you forget, Aiden is hopefully going to help me to make sure that if I have missed a question, that I get back to it as soon as there's a possible opportunity. So thank you for that.
So we do have one question that's posted so far. I'm not sure if you'd seen it, but the question is asking about physical assessment. What do you, as a prescribing psychologist, what actual physical assessment do you do with clients? We haven't really had that really addressed, like how that actually works, in practice.
Sure. I would say over time, very little, but it depends on your practice. So, when I first started practicing, I did my own vitals. I I measure abdominal circumferences whenever possible. I certainly, well, let me take that back. I certainly do laboratory assessments and certainly have had the opportunity over time to increase my repertoire in that regard. But when it comes to actual physical assessments in the visit, in the room, again, when I first started, I would take my own vitals. I would make sure to measure abdominal circumference when it was appropriate, and that sort of thing. We have a mechanism in the clinic that I work in right now where all those things are done by a technician before I actually start seeing my patients. And so I am monitoring their vital signs for sure, especially paying close attention to certain things depending on the medications that I'm prescribing. I'm also ordering, as I mentioned, lab exams as a baseline and as needed during treatment. And on occasion, I have the opportunity, I have done neurological exams and that sort of thing, only as a screener. Obviously, I work in a military health system in which, I can refer a lot of things to the appropriate parties, whether it be the primary care physician to run an EKG, for example, of somebody who's taking, let's say, Celexa or Seroquel or something like that, or to neurology or, internist or whoever may be the primary medical manager for the patient. Did that answer the question?
Yes, it did. Thank you.
Great. Thank you so much. All right, so I'm going to start by saying that, again, because I realize my practice has been mostly in the military, I have to tell you that I'm not speaking for the Air Force. I'm only speaking for myself. So my opinions and everything that we share today do not represent, or what we share today, it represent my opinions and not the opinions of the DoD or the United States Air Force, despite the fact that, as I said before, a lot of my experience, or really truly all of my experience, has been derived um, from the military population. Other than that, I want to start you off. I know you guys are seeing the slides, and so you have a copy of this slide. So I want to maybe, in the interest of time, talk about the fact that talk about the relevance of this course. And I'll start off by saying that this could be, I realize we have tons of material to cover. Some of it is going to feel like drinking from a fire hose, perhaps. And I want to reassure you that this course is intended to be a reference and a guide, something that you can refer back to as you need to, both for the purposes of exams like your comprehensive exam and the PEP, and your future practice, as opposed to facts that you have to memorize. Okay, I look things up all the time, 10 years after I've been prescribing. And it is a lot of material. We certainly have more than enough for us to cover 2 weekends on just gender issues, and potentially, 1 or 2 additional weekends on ethnicity factors. And so I don't, I will start off by saying that I realize that, my briefs, although attempting to be comprehensive, are going to leave some things out. And so I already know that we're going to make overgeneralizations. I know that we're going to, potentially shortchange some topics. And I want to make sure that that I'm aware of that. I've been teaching this course specifically now for, I think, 8 iterations, and we've always changed, updated, increased attention to some things, or changed attention as a result of the feedback that you guys provide. But again, at the end of it all, time is limited, and so we can't get to it all. With that in mind, the relevance of this course has to do with the fact that in every other course that you've taken for the psychopharmacology program, the emphasis, unwittingly and sometimes unknowingly, has been on the psychopharmacology of men. And there's a very good reason for that, and that is the fact that medication trials and some of the history of medical research really has been limited by the fact that a lot of researchers and a lot of pharmaceutical companies that carry out medication trials purposely eliminate women, especially women of childbearing age or reproductive potential, out of the research and out of the trials. So, without having the opportunity to study those populations, again, by default, a lot of the information that you have received in other classes relates to the effect of drugs on men, the medical comorbidities and impact of medication and prescribing on men. And that's not to say that that's not important information. What I'm saying is that the relevance of this course is that we have to look at it from another perspective. All right. I think I'm getting awfully close to being able to pull this up in my on my computer, so that I can actually talk to this slide that I'm addressing, as opposed to talk in general terms. So I ask you to bear with me for just a moment. Oh goodness, where'd it go? Sorry. Okay, the other thing that I definitely want to make sure that you guys know is that, again, I realize there's a lot of material in this presentation, and I will facilitate your learning, hopefully, by emphasizing things that I think are really critical, both to your practice, future practice, or current practice as a consultant, but also hopefully be able to tell you where I think um, the areas of emphasis for the test are going to be. All right. I think what I'm going to do now, if it's okay, is I'm going to disconnect from my iPad so that I can, you don't hear any echoes or anything terrible when that happens. So let's take a 1 minute pause while I disconnect, and hopefully we can get clear. Can everybody hear me now?
Yes.
Okay, excellent. All right. I should have. Okay. As soon as I can get my PowerPoint open, we will get started. On slide 2, you'll see an outline of what we're going to attempt to cover today. Pregnancy is a pretty lengthy topic, and I would assume that we are not going to be able to finish talking about all the areas associated with psychopharmacology and pregnancy until tomorrow. So to be continued. If you look on slide 3, you should see the outline, what's going to happen on slide 3. And okay, I'm going to do this, share screen and the PowerPoint. Okay, can I get confirmation that you are now able to see my screen?
It's coming, Doctor. You just want to kindly yeah, awesome. So now we have it on a full screen.
Okay, excellent. All right. I'll restart the video, and the video may go in and out. I'm not exactly sure if how it's gonna work throughout, but we will do the best we can. Okay, so again, once again, slide 3, you have the outline of what we will cover, or most of what we will cover on day 2, which is tomorrow. Some things are going to be run through very, very quickly, and I will already tell you that because when I first started teaching this class and when I had it taught to me, it was primarily based on female issues, but it is a gender issues class. So I have tried to incorporate issues that are specific to males, in as much as, again, those issues are addressed in other classes. I focus mostly on things that may only be focused within or maybe addressed within the context of a gender issues class. I've also added some material with regards to transgender issues and other issues that seem to be gender related, such as infertility and gender-based violence. In the next slide, I start talking about why this course is relevant. You've already heard my disclaimer, so we'll skip that. This topic is important because of the research bias that I've already described to you. because, you know, as a professionally competent psychopharmacologist, you will likely see more in your daily practice. You will see more women than men. And once again, you will have less reference material, less knowledge, less competence based on the fact that some of that research bias has impacted the information that is available to us. Going back to what I just said, the populations that you serve are more likely to be women than men, simply because women are much more likely to seek help. Depending on where you practice, that may be different. I mean, if you work in the prison system, obviously your clientele is going to be limited to whatever sex the prison system is geared towards. In the active duty population, male outnumber women. In certain career fields, not all, by almost 3 to 4 to 1. And so, you know, my practice has been mostly with men, but that doesn't necessarily mean that I don't see a lot of women. And obviously credentialing purposes and, you know, making sure that you are following ethical guidelines. From the perspective of the PEP, or the psychopharmacology exam for psychologists, I'm not going to spend a lot of time on this slide. So I just want you to know, for those of you who may be thinking about completing the exam in the future, pursuing credentialing in psychopharmacology, how much of the test is actually geared toward understanding the specific needs of some of special populations. And I'll just run through some of the content areas. You see some words highlighted there, some of which we're going to discuss in the context of our ethnicity ethnicity and cultural factors class in the coming weeks. But again, just want to make sure to highlight that this, you know, the gender differences, gender factors are going to be part of a lot of the what do you need to study for, what do you need to know for the PEP. Again, I don't need to read this to you, just want to highlight some items here. And while I'm doing that, just want to emphasize something that you may have heard about already, maybe not, but I think it's important for you to know. And that is when you take the PEP, even though it's separated by content area, even though they tell you, you know, focus on this, study that, a lot of the questions are going to be on the integration of materials. So I'm going to move on so you could see some of the other ones. So, you know, so for example, content area number 1 refers to integrating clinical psychopharmacology with the practice of psychology. That doesn't mean that they're not going to ask you questions that have to do with, you know, pharmacokinetics or pharmacodynamics, or laboratory exams, or, you know, nervous system pathology, et cetera, et cetera. Most of the questions in the exam integrate more than one content area, even though they're gear, they say they target, you know, one specifically. All right, enough of that. With regards to content area 3, the nervous system pathology, you can see some of the areas highlighting are etiological factors in the diagnosis of things like migraines versus migrainous versus non-migrainous headaches. And you want to know sex differences with regards to headache prevalence and presentation. Conditions such as fibromyalgia, which tend to be much more common in women than they are in men. And those are the relevant areas that you would want to know about. Dyskinesias, more common in women than they are in men, especially tardive dyskinesia. And again, you know, even though the PEP doesn't necessarily tell you know the gender differences with regards to this, it is important that you do know that. Again, I'm going to run through this very quickly. I just want you to know some things that are going to be addressed in the scores that are important. Moving on to content area 5, biopsychosocial and pharmacological assessment and monitoring. I think by its very nature, biopsychosocial has to take into account
if gender and sex related factors that may affect an individual that may affect individuals differently. Including things like developmental social history, which may include trauma history, et cetera, et cetera. Moving on. TDM, by the way, is therapeutic drug monitoring. Differential diagnosis, again, one area where gender-related factors are going to be critically important in the consideration of, for example, things like base rates of ADHD diagnosis, in men and women, or significantly the presentation of things like ADHD in the different genders. You know, some of you, I'm not sure if I have anybody in the audience who works primarily with children, but you are all probably aware of the fact that attention deficit hyperactivity disorder tends to be overly much more likely to be recognized in boys than it is in girls, because they tend to have different presentations. Boys tend to be much more hyperactive, and as a result, disruptive, and you know, be cold or be under the attention of both their teachers and their parents, whereas girls tend to be much more distractible, daydreaming, you know, spacing out, you know, but quietly, in a way that doesn't necessarily bring that much attention to their condition as boys get. So those are the kinds of things that, again, you know, differential diagnosis is going to, the knowledge of gender factors is going to help you to enhance your differential diagnosis. We'll talk about absorption, distribution, metabolism, and elimination, or pharmacokinetic factors that affect women and men in different ways. Primarily in this class, we'll focus on pharmacokinetics and pharmacodynamics as they relate to women. Again, with the understanding that you have learned about some of the other processes, some of these things, or some of these processes as they relate to men in other classes. And as far as pharmacology, again, you can see for yourselves. Make sure. Specifically in this area, the impact of things like pregnancy, obesity, age, and I would add reproductive stage are, you know, very important considerations that we're going to talk about in this class. One thing I forgot to mention before, and I apologize, as we go through our housekeeping, as we went through our housekeeping, is that as I mentioned before, I am a clinician. My body and my brain are accustomed to a 45, 50, 55-minute hour for the most part. And so we will be taking breaks frequently in this class, maybe more frequently than in other classes you have taken, I don't know. But at least once, you know, per hour, we'll be taking a very short break. What I do ask is that you try to come back as quickly as possible from the break. I do try to follow a punctual schedule, and again, we have a lot of material to cover, so I want to make sure that we keep us on track. Again, in terms of clinical psychopharmacology, we're going to talk about genetics, pregnancy, and other not that pregnancy is a disease, but disease status, and a few other relevant areas. Knowledge of patient factors, that is culture, literacy, states of change. And again, from a biopsychosocial perspective, whether or not a person is, you know, an individual is going to be help seeking, whether they're going to be following through or, high, whether you would expect a high degree of adherence to their medication regimen, whether or not they're going to be willing participants in treatment planning versus expect more of a paternalistic role of, doctor knows best kind of thing. Those are factors that we're going to talk about both in this class and the future class as well. And then, of course, research. And we talked about the fact that, some the limitations of the current research in that patient selection sometimes, or patient, what's the word I'm looking for? The sample may be actually lacking in both individuals of diverse ethnicities and cultures, but also in women, especially in women samples of reproductive age. And then, of course, we want to know practice guidelines and standards of care for prescribing psychotropic medications, including the relationship with a referring psychologist, which we're going to talk about as I share about my experience as a prescribing psychologist working in a multidisciplinary environment, but also as I talk about sharing a patient with a psychiatrist, a psychotherapy patient, or sharing a patient with an internist or a neurologist, and so on and so forth. Okay, I want to note that previously the PEP, and I've looked at the handbook every single year, to see where the areas of change may be significant. They used to make a note that the complex factors influencing human functioning noted in content areas, as you see listed there, such as genetics, sex, age, disease, and psychological differences, and et cetera, and ecological environmental factors should be considered as they apply across all knowledge areas. And this was another way of saying, again, I'm not sure that even though the note is no longer there, that the circumstances are not the same, and that the PEP is really about integrating knowledge. You're not going to have questions that are specific to psychopharmacology, and the questions that separate from questions that are different from, specific to nervous system pathology. You're likely going to have integrated questions that pull on your comprehensive knowledge of all the areas that you have studied so far and going forward. Okay. So as an overview, I want to make sure that we understand that the main causes of illness and death vary across gender. You probably know that there are different risk factors as well as disease prevalence, both in the psychiatric and in the medical arena for men and women. And a prudent psychopharmacologist needs to recognize the many factors that may influence treatment, which may be influenced by gender. And I do want to say, I'm going to define terms such as gender and sex, et cetera, later on. But I'm going to also make a disclaimer by saying that I will use gender and sex alternatively in this class, and not to offend anybody, because I do know the differences, but also, just to be in line with common use. As you probably recognize in layman's terms, the use of those words are pretty synonymous in certain contexts. And so I apologize ahead of time if I offend anyone, but I want to make sure that you understand that. We'll talk about illness prevalence and incidence, help-seeking behaviors, as I mentioned before, expectations of treatment. Is it supposed to cure me? Is it supposed to help me feel better? Is it short-term, long-term? Am I supposed to be part of the treatment planning process as a patient, or am I supposed to just take the doctor's orders per se and go from there? Things like treatment adherence, or in other, something that you may have heard referred to as compliance, which is a term that I try to avoid because it does indicate a power differential between the doctor and the patient, which is, I think, sometimes unproductive for a prescribing psychologist. We'll talk about comorbid medical conditions and expectations of the provider. So talking about definitions, it's important for us to know that the knowledge of all these factors that have been mentioned before, including gender differences and physiological factors that may affect your drug choice or dose, depending on the status of the patient. Knowledge of fertility cycles and its impact, or the fertility cycle and its impact on drug choice and dose interactions is going to be critically important. And social-cultural influences on gender that may impact drug choice and dose treatment adherence. And by this, I talk about things like medications that may cause weight gain or hair loss. What are the social-cultural differences you might already be thinking about that would impact our ability to prescribe those drugs to women, especially young women, what are the mechanism that affect, the mechanisms that affect adherence beyond the actual positive effect of the drug or the therapeutic effect of the drug. So let's talk about some terms. It's important to understand that sex differences subsumes 4 terms that are as I mentioned before, often used interchangeably, but should be distinguished. We should know the difference. Sex refers to the biological categories of male and female. And when we talk about biological sex, most of the time we are referring to the biological sex category assigned at birth. Most of and we could talk about this for a while. We are going to have some conversation about transgender issues with regards to the difference between sex identifications or biological sex and gender identification. But as you know, sex assigned at birth is based on the external characteristics of biological sex and nothing else. We don't really have, as far as I know, we don't have run DNA tests that tell us whether somebody's birth assigned at sex is categorically male versus female. Gender, of course, is a more complex and socially and culturally constructed variable. It implies a lot of factors that are society specific and sometimes globally accepted in very few cases, but in some cases, gender-related factors can be important in pharmacology. The gender-related factors can be important in pharmacology, but for the most part, they're not well researched. Again, even in those categories of research in which we have sex differences or there's an attempt to address the different responses and factors associated with sex for men and women, gender is really not well researched. So that is definitely an area of where future research could be very important, will be very important. Sexuality, of course, refers to sexual functioning, including sexual thoughts, feelings, behaviors, and attractiveness to one sex versus the continuum of sexual, what we would describe as sexual orientation. Reproductive function refers to behavioral, hormonal, and other changes associated with reproductive system related functioning. And a lot of what we talk about in this class is going to be about reproductive function. Why? Because once again, this is the class where we have to talk about the menstrual cycle and reproduction and pregnancy and post-pregnancy adjustment, as well as I mentioned before, infertility issues. I think that's all I'm going to say about that. And again, with that, the disclaimer that I'm really mostly going to be covering, at least in this setting, mostly going to be covering women's issues, although we'll talk about men's and transgender issues, and that I'm going to refer to sex and gender somewhat interchangeably. All right, so let's start off, and this is where, like I said, I think you might feel like I'm throwing a lot of facts at you, and it may be difficult to ascertain what's important versus not important. I'll try to do my best to highlight those things that I think are important for you to be mindful of, but I will also make sure to send you, share with you a study guide, and also, tell you when things, are just kind of for your, FYI, for your information, or just as to be used as reference material. These 10 things haven't changed very much over time, although they have changed a little, I have to say. The main causes of death in females in the United States specifically, and this is as of 2017. Top 3 haven't changed in a while. The relative prevalence has changed somewhat, not necessarily a lot over the past decade or so. But if you look at it over time, over several decades, many changes have occurred. So, for example, in the United States, several decades back, mortality associated with labor and delivery, or given women losing their lives at while giving birth, was probably one of the top 10. Not probably, was definitely one of the top 10 if we look at potentially 100 years back, and maybe a little bit longer. Some things that have changed recently are mortality associated with Alzheimer's disease. I think it's fairly new that cause of mortality has made it in the top 10. I also want to highlight that there are differences in the causes of mortality for women of different races or ethnicities, to be more accurate. And we will highlight those. Well, you'll get to see this list again, and we will highlight those differences when we talk about the next special populations class. Sorry about that. Okay. I did want to make a change this year and address the causes of death across the globe. I think it's important to understand that whether we like it or not, we live in a global community. Travel, international travel is very easy, very accessible to a lot more people than it has ever been before. And as evidenced by the recent coronavirus epidemic, could potentially affect us, way more than we would have anticipated in several decades past. So across the globe, as you can see, heart attacks or heart disease in this graph, which is by the World Health Organization, described as ischemic heart disease, is the #1 killer, followed by stroke, another cardiovascular disease, followed by COPD. And this, I should say, is for both men and women. Let me see, what are the things that I want to highlight here? Yes, this graph is, sorry, I just need to drink a little. Get some coffee. Sorry about that. Okay, so this is a combined graph of both men and women across the globe. But this chart, I want to make sure to specify, is only for first world countries. So if you look at a graph from the World Health Organization describing the top 10 global causes of death, is going to be different by the economic power, economic development associated with those countries. And as you can imagine, the causes of death in third world countries are much more likely to be communicable and also preventable diseases, such as bacterial illnesses, et cetera, et cetera. And yet you could see a #9 on this list is diarrheal diseases, which most of them are preventable, communicable diseases. All right, going from there, that's not necessarily something you have to know for the test or anything like that. Just wanted to give you an overview. Most common cancers among women in the U.S. And this is the way that this statistics are presented are as estimated new diagnosis for the year 2020. It isn't really, we don't really have accurate numbers as to actual number of diagnoses, for example, for the past 5 years or for the past decade or anything like that. So doing our best to describe this, the estimates are that 30% of cancers diagnosed to women in 2020 will be breast cancer, followed by 12% lung and bronchus, 8% colon and rectal, 7% uterine corpus, which includes some of the reproductive system, and 4% will be thyroid cancers. The mortality for cancer in women is lower than men. And is lowest in Asian Pacific Islander and Latina women compared to other women, especially Caucasian or African American. The mortality associated with cancer overall has always been and continues to be higher for African American men and women compared to other members of the population. And this is an important factor for you to know. When you look at epidemiological issues, you might, you want to think about why is that? Why is it that the mortality for cancers is highest among men versus women? One of those factors likely is help-seeking behaviors. Once again, women are much more likely to seek help of any kind, to visit doctors on a regular basis, to engage in preventative care, including, for example, some of the regular cancer screenings, such as pap smears and well woman exams and breast exams or mammography, et cetera, et cetera. But that may be just one of the factors. We don't know if there's any lifestyle factors or any other areas that could potentially contribute to that. Other leading sites of cancer are listed in front of you. Those are much more rare than the cancers that I mentioned before. Again, breast cancer, that's kind of important to know that breast and lung cancer are the two top for women. Yep, I think that's all I want to say about that. Those are, as I mentioned before, new cases or estimated new cases of cancer in 2020. These are the actual leading causes of cancer death among women. And so while you could see from previous slides that breast cancer is much more common than lung cancer tends to be much more fatal or much more likely to be terminal than breast cancer. And again, that could be related to some of the screening and prevention mechanisms that we have in place to catch this cancers early as opposed to lung cancer. The incidence of lung cancer has been declining since the mid-'80s in men, but only since the mid-2000s in women because of sex differences and historical patterns of smoking uptake and cessation. And you could see some of the other factors there for yourself. Let's see. I've mentioned for breast cancer and many other cancer, the death rates terminal rates are actually higher for African American women versus other groups. And some of the other areas that are listed there. Again, these are things you don't need to memorize necessarily. It's just an important consideration for you to know in terms of taking obtaining a medical history, referring appropriately, and certainly in considering differential diagnosis. Okay. Another area that is differently impacted in men and women is the incidence of STDs. Unfortunately, over the past several years, I would say, rates of sexually transmitted diseases in the United States have continued to rise. And we are seeing sort of all-time highs from the standpoint of, from a historical perspective, and new diagnosis of things that are pretty serious, like syphilis, gonorrhea, and chlamydia. Let's see, what do I want to highlight about this slide? Again, you could see for primary syphilis cases, the numbers in 2018 represent the highest number reported since 1991. And you want to think about what was going on in 1991. We were pretty much in the height of the HIV/AIDS epidemic, and concerns about the transmission of sexually transmitted diseases, and much more emphasis on prevention, a lot more money thrown into education, and assistance with things like with preventable program, or programs that taught STD prevention compared to now. And that that is certainly reflected in the number of cases that are that we see in the present time. Gonorrhea increased 5% to more than 580,000 cases, and that also the highest number reported since 1991. And similar increases in the cases of chlamydia, which interesting to point out, in 2018, this report is 2018, it hit an all-time high in terms of reports of new cases of chlamydia to the Centers for Disease Control. I'm going to talk now about the specific incidence of STDs in females and whether or not they vary by gender, and also by area of the country. And I think it would be really, really interesting to consider some factors that may be associated there. Okay, chlamydia is about 2 times more common in females than it is in men. And the rates in the South are much higher than in the rest of the US. And again, I don't have any facts that I could share with you about why that might be, but I think you can sort of, critically think about why this may be for yourselves. Gonorrhea is highest incidence is for men versus women. Syphilis also have a higher incidence in males than in women, and the highest rates are in the United States, in the Western United States. HPV, or human papillomavirus, is the most common STD. It's responsible for 90% of genital warts cases. The rates in women are a little bit less than males, but they're pretty similar. They're not all that different. And by some estimates, 42% of sexually active adults carry the human papillomavirus. Just was able to open up the chat, and I see from Kirsten, I work in a primary care clinic. Unfortunately, I hear too much about this in adults and teens, both from consensual sex and not. Yeah. Again, I don't, I can't report to, I can't say that I understand completely why this is the case, but I know that there's been a significant change over time with regards to sex education, sex prevention, and also the funding of both community-based and government-based services that aid in the prevention of some of these diseases. Now, as you know, HPV has, has been addressed in the recent past with a vaccine that is both available to men and women, mostly boys and girls, because the first time that the vaccine is recommended is in the preteen, is for preteens. Rates of effectiveness are Still, I think questionable, and there's been a lot of controversy, as I'm sure you know, from vaccine and anti-vaccine advocates as to how, drug companies, sort of push this and whether or not it truly is effective. And I'm not going to get into that right here, right now, but I do want to say that there is a vaccine available for the HPV. And then and finally, I included the Zika virus, which you heard much more about a few years back versus now. Now we are all in the midst of, learning more about the coronavirus. But the Zika virus, I can be passed from person to person during sex. So it has to be considered as an STD, because even though the majority of infections were not contagions from person to person, they could be passed from person to person during sex, and also could be passed from mom to child in utero. All right. I think since we're getting close to the hour, I'm going to cover this slide, next slide, which is slide number 37, and then we're going to go and take a 10-minute break. So some consequences of STD for women that you should be very familiar with, and hopefully have learned about some already through some of your courses, and we're going to talk about to some extent here, are pelvic inflammatory disease, or PID, which can cause infertility in about 8% of women, can also lead to ectopic pregnancies in a significant number of women, as you can see, and chronic pelvic pain, and therefore a significant decrease in quality of life in almost 1 out of 5 women. So STDs are not inconsequential, is what I'm trying to say here. HPV may lead to cervical cancer and other reproductive system cancers. Chlamydia and gonorrhea can result in neonatal ophthalmia and neonatal pneumonia. And I'm not exactly sure why I added chlamydia at the end of the sentence. I think maybe I meant to say that it can be passed, the disease itself can be passed on to the child, but I'm not certain, so don't quote me on that. And then congenital syphilis can lead to fetal death or physical and mental disabilities or deformities. So, again, these are not serious consequences. Sorry about the double negative. These are very serious, could have very serious consequences for both mother and child in terms of health and quality of life. All right, with that, I'm going to go ahead and start a 10-minute break. According to my watch, it's 12:59, so we'll come back 9 minutes after the hour. And if you have any questions, you can go ahead and post questions to the chat, or like I said, when we come back, if you want to unmute your microphone and ask me, that would be great. Thank you. Try to change the screen a little bit. Sorry, I think let me move my chat out of the way. Want to make sure that everybody can hear me. Can you confirm?
Hear you, Dr.
Yeah, I can hear you.
Excellent. Thank you so much. Okay. So we covered slide 37 already. That's what we left on. I'm going to move on to talk about other illnesses that are important for you to know about. Things that may affect women and men differently, and specifically at this point we're talking about women. Diabetes rates are slightly lower in women than men. Not a huge difference from a differential diagnostic perspective, but there is a difference. Ulcers tend to be about the same rates between men and women. Kidney disease equally prevalent, same as liver disease. Arthritis rates are much higher in women than they are in men. Chronic joint symptoms also tend to be higher. Headaches, and especially migraine headaches, tend to be twice as common in women as they are in men, with one exception, and I do want to point that out. Thanks, Abdullah, for that comment. I do want to point out that there is one specific class of headaches that is more prevalent in men and women. And if anybody knows what that is, you could type it in the chat. That would be cluster headaches. So cluster headaches are something we're going to talk about later, probably tomorrow. But as a kind of a nugget, definitely want to give you the heads up that that is one significant area in which headaches are more, one type of headaches that is more common in men than in women. Neck pain, lower back pain, and face or jaw pain are higher rates for women than they are for males. So as you can see, a lot of the pain conditions, and you know, the last 2, 4, 6 on this slide are all pain conditions, are significantly more prevalent in women than they are in men. Okay, with regards to psychiatric, well, medical illnesses that may present with psychiatric symptoms and that have higher prevalence in women, you should know about MVP, or mitral, not most valuable player, but mitral valve prolapse, which is essentially an arrhythmia that may be related and or present with symptoms that resemble a panic attack. Both MVP and panic attack can be comorbid, so one doesn't necessarily rule out the other. What's important is that they're both accurately diagnosed and treated, because for women who have arrhythmias such as MVP, anxiety could be a significant, both precipitating and also an exacerbating factor to those arrhythmias. Thyroid disease, both hypo and hyper, present at higher rates in women, especially in women over 40. Lupus is also more prevalent in women, as well as iron deficiency anemia and IBS. And again, if you know anything about IBS, you probably know that there's a significant correlation between IBS and anxiety. And so those are definitely conditions that have psychiatric illnesses and psychiatric presentations, and potentially comorbidity considerations. Let me see if I can. All right. As far as other epidemiological issues, there are psychiatric illnesses that affect women and men in different ways, although the prevalence rates may be exactly the same, such as schizophrenia. By all accounts, about 1% of the world population may suffer from schizophrenia. However, women tend to have a very different course than men. They're less likely to have structural brain abnormalities on scans, less likely to have comorbid substance abuse, though it depends on the population, less likely to commit suicide. Women in general are less likely to commit suicide, and you will see that when we talk about the top 10 causes of death in men. More likely to have relatives that have the illness, so it's easier to see a biological pattern or the biological loading of the disease in women. More likely to have late onset schizophrenia, late onset defined as late 20s to early 30s, as opposed to typical onset of schizophrenia for men being in their late teens and early 20s or early adulthood. They're also more likely to exhibit more positive and less negative symptoms. If you recall the difference between positive and negative symptoms, positive are things like delusions, hallucinations, bizarre behavior, and bizarre or agitated behavior. Negative are things like anhedonia and other symptoms that are much less disruptive, quote unquote. Exhibit more effective symptoms. So in that vein, may be more likely to present with things like schizoaffective disorder, especially depression, with a significant presentation of depression, and also potentially with symptoms of bipolar as well. Tend to respond to lower doses of neuroleptics, and I already told you before that they also are more likely to develop tardive dyskinesia. So you would be very wise and very within, it would be very appropriate for you to consider using lower doses of neuroleptics for women, and trying to maintain that at the lowest dose possible in order to minimize those side effects. And tend to maintain better social functioning in general. High rates of employment, marriage, and other social areas of functioning are visible in women. So again, a very different course of the illness, and these are, of course, generalizations across large groups, not specific to one case, but those are things that are important to know, especially if you treat folks that have serious and persistent mental illness. With women who develop the diagnosis of schizophrenia, it's really important to assess for things that you may not think about, and obviously wouldn't think about with men, such as assessing for symptomatic variation across the menstrual cycle. You may see a higher prevalence of some of those positive symptoms, such as delusions and hallucinations associated with changes in the menstrual cycle. And so it's important to keep that in mind. You want to also inquire about menstrual irregularities, and we'll talk about different types of menstrual irregularities later today. It's important because of the effect that some of the neuroleptic medication, antipsychotic medication, has on things like hormonal levels, such as prolactin. It's really important to measure prolactin levels. I would say both in men and women, but certainly in women, and as we're talking about here. Because of the condition itself, it's really important to counsel women about the risk of unwanted sexual advances, and also about the risk of risk associated with unprotected sex. Want to counsel young women with schizophrenia about birth control use, and inquire about situations of recent unprotected intercourse, and definitely assess for STDs. And one thing that I would say, I was asked a question before about physical exam. I have order STD panels for women. Obviously, I don't treat STDs, but if I'm the first person to hear word that somebody's engaged in, someone has been assaulted or engaged in unprotected sex, or that sort of thing, I will refer them to the appropriate medical provider. But in order to ease their mind, I have ordered in the past pregnancy test, and also STD panels. As far as other mood, but mood disorders, depression is twice as high in women as it is in men, and that is a cross-cultural finding. Unfortunately, persistent depression, otherwise known as dysthymic disorder, or previously known, I should say, as dysthymic disorder, is almost twice as high in women versus men. 6 times higher rates of seasonal affective disorder, or SAD. Bipolar mania, once again, another pretty biological diagnosis. Bipolar rates are roughly about 1% throughout the world, and men and women have equal rates as well. But once again, like we see with schizophrenia, the course of the disease may look a little bit different for men and women. Women are more likely to be rapid cyclers, more likely to develop a lithium-induced hypothyroidism, therefore checking, do NTSH screenings routinely is very important, and potentially considering alternatives to lithium. Excuse me. May experience more depressive episodes throughout the course of their condition, and it is very possible that you first encounter them in the midst of a depressive episode versus an episode of mania. So you want to be on the lookout for using antidepressants that may potentially based on their family history and based on their presentation, be on the lookout for antidepressants that may potentially trigger a manic episode or, a switch to mania. And then may also experience more mixed episodes, also known as cyclothymia, same as rapid cycling. Just as an FYI, the definition of rapid cycling is 4 or more episodes per year, and that could be episodes of depression and mania, or mixed episodes where both symptoms of both are present. Need to understand also in the cases of women with bipolar disorder that there could be mood deterioration associated with the premenstrual cycle. It may be helpful to obtain blood levels of medication premenstrually and in the week after menstruation, because the serum levels of the drugs may fluctuate. So in terms of assessing both adherence to the medication regimen and response to the medication regimen, you need to understand what may be going on with the patient from a hormonal perspective. Women with bipolar disorder are also at increased risk of postpartum psychosis. So that, this is one category of patients that you want to watch really, really carefully, and as much as possible engage in pre-pregnancy counseling, which we will talk about later on. Although, understanding, the limitations of, what what we can do in those situations. Let's see. What else do I want to highlight about mood disorders? You'll hear me say this before, but repetition never hurt anyone, especially when it comes to an important concept. Several of the mood stabilizing medications that are used to treat bipolar disorders, such as the anticonvulsants, are associated with severe fetal malformations. Therefore, again, that pre-pregnancy counseling could be very critical, and psychotherapeutic mood management can be pretty critical. And also, it's important to point out that a lot of those, or several of those mood stabilizing medications, especially Lamictal and Topamax, can decrease the effect of hormonal birth control efficacy. So please, please, please know that women who are taking anticonvulsants are at a higher risk of having their birth control fail them, quote unquote, because efficacy rates of hormonal birth control do tend to fall with the interaction with mood stabilizing medications. And therefore, it's really important to counsel women to use another secondary form of birth control, like, more so than anything else, a barrier method of birth control, such as condoms. Okay. By the way, and I didn't say so before, I may have not made it clear before, but if you have any questions along the way, feel free to, again, unmute your microphone, go ahead and ask. You don't have to wait until the end of the session to ask questions. Okay, we've covered psychotic disorders and mood disorders. Let's talk about anxiety disorders. And as you all know or can intuit, anxiety disorders are much more prevalent in women than they are in men, with panic disorder and generalized anxiety disorder rates being 3 times higher, social anxiety 3 to 4 times higher. Although I have to say in my clinical practice, and again, I have to caveat by the fact that most of my patients are, in general, a lot of my patients are male because of the number of males in the military versus women. I see a significant number of men with social anxiety. I think we underestimate the rates sometimes of social anxiety in men. But the prevalence or the epidemiological studies do show a rate of social anxiety that is 3 to 4 times higher in women than in men. Obsessive compulsive disorder, once again, another category of psychiatric illnesses that seems to be pretty biologically based. equal rates between men and women. But once again, we see a different course. And, you know, it's really unclear how this happens. But this, if nothing else, it highlights why it's important to have a gender factors course, because, you know, I think otherwise, you know, we might assume that schizophrenia, bipolar, and you know, things like obsessive compulsive disorder kind of fit one mold, but they don't. Women tend to have a later onset, just like they do for bipolar and schizophrenia. More obsessions associated with food and weight are common in women. And they also, and it's also important to consider comorbid eating disorder, especially for women who have very serious OCD with food and weight compulsions. They may manifest it themselves as restrictive type of food or eating disorders, such as anorexia. Post-traumatic stress disorder, I know intuitively it may not seem so, especially for those of us who work with active duty and veterans, but the rates are twice as high in women than they are in men, despite similar lifetime prevalence of exposure to trauma. And in this, we have pretty good research that says that the difference in prevalence rates of PTSD versus the prevalence of exposure to trauma is best explained by the fact that most of the trauma that women experience and develop or have the likelihood of developing PTSD from is personally based trauma, gender-based trauma, such as sexual assault and domestic violence. For several reasons, again, which you can probably intuit, those categories of trauma affect people differently and have a higher prevalence of PTSD versus things like motor vehicle accidents or even combat-related traumatic events. It's important to know, you know, we talked about eating disorders, and let me make sure that I'm not jumping ahead. Yeah, we talk about eating disorders next, so let me make sure I highlight what's important there. Okay, I think we're good. We got, with regards to eating disorders, a much higher rates of anorexia nervosa and bulimia nervosa patients who are women. Although I would have to say that, again, increasingly we see higher numbers and in my own clinical experience, and I know that's completely anecdotal and not evidence-based, increasing numbers of men who experience this categories of symptoms. Appetite suppressants and herbal supplements are more commonly used by women. We can see purchasing trends, and you know that women tend to buy these things more often than men. And it's important to know that they may be associated with anxiety reactions. And in contrast, steroids, which are more commonly used by men with things like anorexia or even things like much more significantly, things like body dysmorphic disorder can be associated with anxiety symptoms as well. So keep an eye out for that. It's really important with eating disorders that we consider evaluating menstrual patterns. As you know, one of the hallmarks of anorexia, especially in the severe and the more severe presentations of the disease, is actually the lack of menstruation. And so it's important to make sure that we're asking questions as part of the medical history. Self-induced vomiting is common with eating disorders, as is the use of laxatives, diuretics, and enemas, emetics, or diet pills, and as well as the use of alcohol or other illicit substances that may be seen to be correlated with decreased appetite, including stimulant medication. Physical and dental exams are absolutely a must, and I think it would be malpractice as a prescribing psychologist if you did not refer somebody with an eating disorder for both a full physical and a full dental exam. The dental exam, because of the vomiting, self-induced vomiting, and potential nutritional imbalances, and the physical exam because of, just about everything else, metabolic imbalances, cardiovascular risk, et cetera, et cetera. And I give you in this slide, only because this is the only slide in which I'm going to talk about eating disorders, I give you some suggestions with regards to laboratory studies that you might want to order. Once again, the idea would be to assess and refer. Obviously you're not going to treat nutritional imbalances or potentially liver or kidney complications. But you might, this might help you assess, for example, the extent of self-induced vomiting, the potential risk of cardiovascular, potential risk for cardiovascular involvement, and anemia and other things that would complicate the clinical picture. So once again, I would harp on the idea of assess and refer. And, eating disorders are complicated, quite complicated to treat, and in most cases require both a team approach and a lot of consultation among providers and elevation of care as needed, depending on the severity of cases. Okay, with regards to sleep disorders, they're also more common in women than they are in men. The risk rises during certain reproductive phases, as you probably already know. Sorry, my this is part of the danger in sharing the screen. I'm going to put myself in do not disturb mode. Okay, certain phases of women's lives, pregnancy, first trimester, first and third trimester may have complications with regards to sleep patterns, with women reporting, a lot of women reporting hypersomnia in the first trimester and insomnia in the third trimester. Premenstrual, there may be premenstrual changes. And sorry about that. Okay. Premenstrual changes in sleep patterns with more insomnia, and perhaps again in other women, hypersomnia in the premenstrual phase of the cycle. Let's see, what else do I want to say about that? Menopause or perimenopause can also be associated with sleep problems, in that it's not uncommon to see some of those cardiovascular symptoms, such as hot flashes, cold chills, et cetera, autonomic, discomfort be associated with sleep difficulties as well. In essence, the woman cannot stay warm enough or cold enough to be able to obtain a good number of restorative sleep hours. Concerns with regards to sleep disorders are assessing for the comorbid presence of anxiety or depression, and also for medication side effects, which could be prompting those sleep difficulties, including the use of bronchodilators, such as those used for asthma, exercise-induced asthma, and other respiratory illnesses, blood pressure medications, decongestants, nicotine, and caffeine. So we definitely want to make sure to get a good and complete medical history when assessing for sleep disorders. And I would say both in men and in women. Now we're going to try next the first poll question. So Aiden has been good enough to help us with this, and hopefully this is going to work. I'm just going to give you give Aiden a few moments to post the first poll. There it is. Go ahead and answer the question to the best of your ability. And I'll post the results in a minute. We have a comment from Najib who says he can't see the poll. Aiden, is there someplace different that he should be looking at other than the main screen?
I'm gonna just post the question inside the chat room.
Okay, sounds good. Thank you. All right, I'm just gonna give it a couple seconds and we're gonna go ahead. Can we end the poll and post the results? Great. Okay, so here we are. I hope everybody can see it. The poll was closed with 19 folks, or 80% of respondents, saying it is true that women are less likely than men to die from intentional injuries, that is suicide, versus 14% saying false. And it is true. The right answer is true. Women are more likely to attempt suicide. That is still true today, as it has been for a number of years. But men are more likely to actually die from suicide or take their own lives. Okay, good job. And I know we hadn't covered mortality yet, but we did address that. So great. Okay, let me go ahead and I'm going to close the poll and continue. And thank you for participating. Actually, never mind, I shouldn't have closed the poll. Sorry, Aiden, can you go ahead and post poll question number 2? I didn't realize we had another question coming through. Great, thank you. So what you should see in front of you, the question reads, all of the following are true about the consequences of STDs in women except. And you have some choices there. Okay, so with about 80% of you haven't responded, I'm going to go ahead and end the poll. So give you 1 or 2 seconds in case you want to go ahead and post your answer. If not, let's go ahead and share the results. And the correct answer, which 95% of you endorsed, was congenital syphilis does not lead to fetal death or physical or mental disabilities. It does lead to, in some cases, has led to fetal death or physical or mental disabilities or malformation. So the correct answer is D, or number 4, depending on how you're looking at this. And most of you made the right choice. Thank you. All right. So this is one way that we are going to both highlight the important areas to consider for studying and for the test, and also to practice and rehearse the information that you have just received, because as I mentioned before, there is quite a bit of information that we're going to go over, and I understand that it may feel like drinking from the fire hose. Okay. Let's move on. I'm going to talk about pharmacokinetic and dynamics and some sex-specific responses that you should be aware of. As you know, pharmacokinetics refers to how the drug moves across the organism. So the effects of delivering the drug and removing the drug from the site of action. Versus pharmacodynamics pertains to the drug's mechanism of action, or how it affects the organism, the effects on the body. So pharmacodynamics, the body's effect on the drug; pharmacokinetics, the body's effects on the drug; pharmacodynamics, the drug's effects on the body. For alcohol, women become more impaired, alcohol being conceptualized as a drug, of course, in this case. Women become impaired sooner and remain so longer, meaning they show a slower elimination of alcohol. It may show greater impairment around premenstrual period. So it is possible that women's cycle may affect their metabolism, their elimination of alcohol, to where consuming the same amount that they may consume at other times in the cycle may lead to greater impairment. And that's something that's important for you to know. As far as pharmacodynamics, as I said, the drug's response on the body, we see decreased amount of alcohol dehydrogenase, which is the enzyme that breaks down alcohol, as you know. Body composition and size play a part in the pharmacokinetics with, alcohol related complications. So let's see, such as peptic ulcer, hypertension, liver disease, anemia, and cerebral atrophy developing more quickly in women who also have higher mortality rates. Let me see if there's anything else that I want to share with you about that. We do see that this decreased amount of alcohol dehydrogenase is less active. The lesser activity in women, which means that larger amounts of alcohol will actually be absorbed into the bloodstream as opposed to deactivated, for lack of a better way of saying it. And obviously, if not detoxified by the liver, will be present in the and ready to interact with other medications and other substances, which may be part of the reason for this increased number of medical complications. As far as other substances, abuse of hallucinogens and opiates tends to be lower in women, but cocaine and amphetamine abuse show pretty similar rates. And prescription drug abuse, interestingly enough, it used to be more common in women. When it used to be less common, it was much more common in women Why? Because women tended to go to the doctor more, and they tend to receive prescriptions of medications such as opiates and other um, uh, uh, dependent or addictive type of medications at higher rates than men, including things like benzodiazepines. Nowadays, of course, we have a different story going on. With higher numbers of prescription drug abuse, we also see a higher rate of prescription drug use in men. Prescription drug abuse, I should say, or non-medical use of prescriptions. In men, you can see the numbers there: 2.6% in men, 2.3% in women. Lots of complications. This is not the primary focus of this class, so we don't need to, necessarily spend a lot of time. But I did want to make you aware that those trends have changed in the recent past because of the opiate prescription abuse epidemic. Let's see, youth. In youth, there is a significant difference between girls and boys for the use, non-medical use of pharmaceuticals, especially as related to emergency room visits. Let's see, higher rates of use in youth than we've ever seen. Okay, and I think that's all I want to highlight from this. As far as death from overdose, about 30 males in 100 per 100,000, 10 females. So the death rate is still very much heavily loaded toward men versus women. The highest risk groups from 2004 to 2015, and I'm not sure if they have changed drastically in the past few years, have been 45 to 54-year-olds. And some with rates that are high, steadily increasing in other age groups that you see listed in front of you. Okay. Again, this is not an area of emphasis in this class. I just wanted you to see the gender differences or sex differences in this problem, since we are talking about alcohol and other substances that could be abused. Okay, so I'm going to talk a little bit more. We mentioned some as it relates to drugs of abuse, but I want to talk about sex-specific responses with regards to pharmacokinetics and pharmacodynamics. It's important to point out that hepatic metabolism may be slower in women, and there's a mechanism of action presented on this slide for you, potentially estrogen's inhibitory effect on some of the hepatic enzymes may be at play. These are all theoretical mechanisms of action. We don't know for a fact that this is the one and only contributing factor, but it's something to be aware of. Progesterone may influence drug absorption by delaying gastric emptying time. And another thing that I would want to highlight, if you've been a woman or know a woman, you probably know about water retention and water elimination changes throughout the menstrual cycle. And depending on the drug, there could be significant changes in drug absorption and metabolism based on water levels as well, especially for drugs that tend to be water, what do we call them? Lipophilic versus, hydrophilic. Estrogen and progesterone are highly protein bound and may compete with psychotropic medications for protein binding sites. So once again, we could see differences in responses based on the different levels of estrogen and progesterone and during different parts of the reproductive cycle, as well as during different phases of the menstrual cycle. And we're going to talk about levels of hormonal levels throughout the menstrual cycle a little bit later. Okay, other sex-specific responses you should be aware of in pregnancy. of, with regards to pharmacokinetics, we see delayed gastric emptying, decreased GI motility, decreased volume of distribution, decreased protein binding, and increased hepatic metabolism. And all of that can affect both the duration of the effect of the drug in the body as well as the body's response to the drug based on the on dosing, of course. As you can imagine, if there's decreased pharmacokinetics, then potentially less of the drug may be available, or more of the drug, depending on the drug, may be available for the actual effect, or at the binding site, I should say. Let's see. There's been documented changes or effects in young adult to middle-aged humans for gastric emptying rate, basal gastric acid secretion, gastric oxidation, weight, body composition, brain blood flow, hepatic biotransformation, and creatinine clearance. And I don't need you to memorize these things. I mean, they seem pretty complicated, and I know that they are the focus of other classes that you've taken. It's just important to know that there may be not just sex related, but also, as you could see, age-related changes, because the point here is that in young adult to middle-aged humans, these things may be different. So if you have a geropsychology practice, or if you treat mainly children and adolescents, some of these things may be different for your client population as well. Okay. In general, what I do want you to know is that the bulk and weight of the evidence point to slower gastric emptying in premenopausal females compared with males. And females having lower total blood volume may show somewhat higher serum concentrations of water-soluble drugs compared with males. Most effects go in the same direction, though not all. And once again, it is really important to not make overgeneralizations, but make assessments based on the individual conditions or the individual factors that your client presents with. In that direction is that these effects tend to increase the blood levels and decrease the clearance, meaning that the dosing may need to be lowered. If you have increased blood level and decreased clearance, no longer is the same dose potentially having a stronger effect, but it also may have a longer lasting effect. This is true for drugs metabolized by the liver, but it's important to point out that those that are metabolized primarily by the kidneys may be an exception. And there's not a lot of drugs, as you know, that are metabolized by the kidneys. We're going to talk about those exceptions when it comes to the benzodiazepines and lithium. But again, just, in essence, again, if we go back to the several slides, including, what is this, 51, 52, and 53, the bottom line that I want you to be aware of is right here. The idea that most effects are going to ultimately result in increasing the blood levels and decreasing the clearance of most drugs, especially those metabolized by the liver, and especially those that may be water soluble. Okay. Now we can't have I feel it's important to point out that we can't really have a discussion about sex or gender factors without talking about environmental and socio-cultural factors. And we don't really want to. As I said before, in preparation for the PEP exam, one of the key factors of the courses that you've been taking and the areas of study that you've undertaken is that we don't want you to forget how to be a psychologist. It really is important that you don't forget how to be a psychologist, and the fact of the many areas and the complexities of your clients' lives that you need to understand in order to be a good and informed prescribing psychologist. And those have to include environmental and sociocultural factors. So you'll see me present both in this course and in the future course, the picture that you have in front of you, which is called which I call the genetic wheel, but it could be just about anything. The idea being that we all have a genetic constitution, meaning our genetic makeup, whether you call it our DNA, our biological loading, et cetera, et cetera. Our genetic composition is at the core of who we are. And yet there's a multitude of factors, some of which you see highlighted in this picture with bi-directional arrows that both are affected by our genetic constitution, but also affect our genetic constitution. Things that are environmental, like occupational exposures, diseases, exposure to sunlight. Let's see, what else can I look at from an environmental perspective? Dietary factors, circadian and seasonal variations, as well as social and behavioral and cultural factors that could affect who our clients are, who we are as individual human beings, and that again play a part on each other. So once again, the main thing that I want you to take away from this graph, which I hope you can see and follow, is that both our genetic constitution and those socio and environmental and biological factors that are external to us impact one another in a way that is ever present and ever evolving. So because of that, I guess the point that I want to make is some of those things that I talked about before, the gastric emptying and the pharmacokinetics and pharmacodynamic predictable effects may be counteracted by these interactions between the environment and the individual in such a way that it may be unclear as to whether they matter or matter more for an individual versus another one. Okay, the following slides are pretty interconnected. So I think for that reason, and looking at the clock, I'm going to go ahead and start our next 10-minute break. And when we come back, we're going to be talking about sex differences in the burden of mental illness, not just in the United States, but across the world, as a way to give you a framework for how we're going to talk about treating those conditions from a psychopharmacological perspective. All right, so I got 1:59. I know you guys are 2 or 3 hours behind me, depending on where you are, but I got 59 minutes before the hour, so let's go ahead and come back in 10 minutes. We're back. And we're going to move on to talk about gender and sex burden of mental illness, both across the world and significantly in the United States. I was looking a little bit ahead. I think we're going to stop for lunch at slide 78 or so, which is where we start talking about the topic of menstruation. So we have a couple of topics that we'll cover right before lunch, including what I just mentioned, as well as hormones and their impact on, and hormonal changes that may impact women and and function, hormonal considerations related to psychiatric illnesses. And then after that, we're going to break for lunch. Okay, so with that, let's move on to slide number 56. Can I get confirmation in the chat that you guys are able to hear me and see the slides? Okay,
Hear
great.
you, Doctor.
Excellent, thank you. Okay, I mentioned already several classes of psychiatric disorders and how they affect women and men, and sometimes similarly and sometimes differently. In general, when we look at psychiatric disorders, the rates are identical for men and women, but there are striking differences in the patterns of mental illnesses, and some of those I've already discussed. What's important to highlight, and this is out of a report by the World Health Organization, or the WHO, in 2013, and believe me, I've looked for updates to this report. I haven't seen anything yet. Is that the disability associated with mental illness is most heavily, or tends to fall most heavily on those who experience 3 or more comorbid disorders. And in this case, women predominate. So even though the rate of psychiatric disorders are identical for men and women, at the end of the day, women tend to be more, to fall more in the category of women, people who have comorbid disorders, especially 3 or more, and therefore experience the burden of mental illness in a very different way. Some risk factors that you can intuit likely affect women disproportionately across the world are sex-based violence, including domestic or partner related violence, and sexual violence, of course. Socioeconomic disadvantage, disequal pay, dis or unemployment or lower employment, and of course low income and income inequality. And by the WHO's account, 70% of the world's poor are women. Low or subordinate social status and rank. Again, I'm talking across the world, not just in the United States, and continues and somewhat unrelieved responsibility for the care of others. And you can think of it along the lines of the care of children, but also the care of parents and elderly, as well as disabled members of their families. With regards to environmental and socio-cultural factors, sexual violence is, the correspondingly high rate of post-traumatic stress disorder associated with sexual violence makes women the largest single group of people affected by this disorder. Again, a quote from the WHO. I've mentioned already that we do have very I think a very solid research base that explains the differential rates of PTSD in men and women as a relationship of the trauma, the specific traumas that they seem to experience. Women are reluctant to disclose a history of violent victimization, and it's important in this regard to consider whether we're even asking the questions. Our physicians, health workers, nurses, doctors, etc., and even preventative health programs willing to ask about victimization directly. How many in how many of our environments, or the environments that we work in, or that other people receive primary care, for example, are they being asked the question of whether they feel safe at home, or whether they're being victimized in any way? The complexity of violence-related health outcomes increases when victimization is undetected and results in high and costly rates of utilization of the health and mental health care system. That's pretty self-explanatory. I am curious, and we didn't have an opportunity in the beginning, but now that I can see the chat box, if you guys would mind sharing with me the type of setting in which you work, whether it's private practice or hospital or community-based or whatever, however you want to describe it, person, etc. And whether or not you have any kind of screeners at the primary care level, or or know of any buddy in your community at the primary care level that is asking questions about victimization of all their patients. So I'll give you a minute to post, again, the type of setting that you work in, and a yes or no for whether clients are screened for being a victim of domestic abuse, sexual violence in any way. Okay, so what I see so far, just make sure I keep track. Group practice, private, no screener, but good idea. Najib says pharmacy. Monica says a primary care geriatric clinic. We don't screen. We did at Kaiser regularly. Very good. Private practice and private agency. We ask about trauma, but not specifically DV. Najib says no screening. Yes from Kiara. Men and women jails. Private practice, yes, screen. Work at the VA at the PTSD clinical team, and we routinely screen for MST. That's great from Eddie. Primary care clinic, patients are asked yes or no for violence, but not pursued unless patient wants to. Interesting. Utilization and review, admin. SUD residential, IOP and ODF, yes. For screen, yes. Male prison, childhood family violence is at intake consideration. Great. Private practice and community underserved respite clinic, university counseling center, 2-question screeners. Great. Thank you for your inputs. I think it's remarkable to see both the settings and also the many different ways that these issues are addressed. Whether or not the women are asked about their answer, if you do have a screener, could potentially, have significant consequences as to whether women ultimately get help. But just the fact that you're asking the question is a great place to start for women who may be afraid of coming clean or self-disclosing, and that may be ashamed or have multiple barriers potentially to be able to disclose and get help. Carmen says, I work at NASA and I doubt there's a screening. I'm starting a behavioral health program with former astronauts. I should screen. Great points, thank you. A 2-question screener has been found to be incredibly effective, and we'll talk more about that when we touch on domestic violence tomorrow. And the 2 questions are easy. I think one of them is, do you feel safe at home? And the second one, and I'm blanking out on the specific wording right now, again, we'll talk about it tomorrow, is, more specific. Are you being victimized, or, are you, is somebody exerting power or control over you in a way that makes you feel afraid? That's not the specific wording, but it's more specific. Again, the first non-specific question, do you feel safe at home, can certainly be the opener for conversations about whether somebody lives in the inner city setting or a high crime area, or potentially within the context of a spouse abuse or domestic violence, as well as several other things. So great inputs. Thank you for sharing. And again, I just want to emphasize the importance of just doing the screen. But again, making sure that we follow up whenever possible. Okay, when it comes to sexual assault specifically, it's important to note that 1 in 4 girls and 1 in 6 boys will be sexually abused before they turn 18 years old. So the sexual assault is not a woman's issue. Sexual assault is a human issue. And I think this highlights it more than anything else. And yes, I do want to emphasize, and we'll talk about that as well, that most of the time the perpetrators of sexual violence are men, and the majority of perpetrators are men, but both girls and boys are affected by sexual abuse. When it comes to sexual assault, it's a little bit different. More than 1/3 of women who report being raped before the age of 18 also experienced rape as an adult. And rape is much more common in women than it is in men. Rape is the most underreported crime. You see the numbers in front of you. 63% of sexual assaults are not reported, so that would be 2 out of 3. More than 90% of sexual assault on college campuses are not reported. That is frightening and disheartening in so many ways. As I said before, sexual assault affects women and men, but it, specifically for women, affects women of all ages and cultural, ethnic, and economic backgrounds. It's not a young woman's problem. The lifetime prevalence is 1 in 5 women and 1 in 71 men. Victims may present with vague physical complaints: fatigue, disturbed sleep and appetite, headache, muscle aches, and pains. And so if you work in an integrated healthcare setting or even in primary care, it's really important to be attuned to some of those complaints potentially being signs that somebody may have been assaulted or abused. Medications may be helpful in treating depression and post-traumatic stress disorder, as well as anxiety symptoms, but be wary of benzodiazepines, as they may complicate the natural recovery from PTSD. And, I think, which one of you? Eddie said you work in the PTSD clinical team at the VA. I'm sure you're keenly aware of the complications of using benzodiazepines with victims of trauma. As I mentioned before, it can actually preclude their natural healing and their recovery, and may exacerbate the course. So I have the questions in front of me now. Do you feel safe at home is the first question. The second question: has anyone at home or in your environment hit you or tried to injure you in any way? Two screening questions that have a 71% rate of sensitivity and an 85% rate of specificity to be able to assess for sexual assault and domestic violence. So please consider using. They are not copyrighted as far as I know, and I think it's really relevant to make sure that we incorporate the knowledge as much as we can. We're going to talk about this in our future class, but I do want to highlight that there are some ethnic differences in rates of assault and abuse, with almost half of multiracial women and over 45% of American Indian or Alaska Native women reporting being subjected to some sort of some form of contact. Sexual violence in their lifetime. And of course, just want to highlight the lifetime consequences, both in, physical and psychological health problems for women and men who have experienced sexual abuse as children. Okay, so let's consider whether there are 6 biases or differences with regards to mental illness. It is important to point out, again, I haven't seen a more recent report and I have no reason to believe it has changed drastically, although that, there's a possibility in mind. Doctors more likely to to diagnose depression in women compared with men. And this even when they present with similar scores on screeners and standardized measures of depression or present with identical symptoms. So is there a bias or is there a difference? Again, earlier I mentioned that women are twice as likely to experience depression, but it may be that women are twice as likely to be diagnosed with depression, despite the fact that men may present with identical symptoms and even identical scores on symptom screeners. Female sex is a significant predictor of being prescribed mood-altering psychotropic medications, with women over 50% more likely to receive an antidepressant or an anxiolytic during the doctor's visit compared to men. Women are more likely to seek help from and disclose mental health problems from their primary healthcare physician. And it is important to highlight that men are more likely to get specialty care. So when men do seek help, they're more likely to go to a specialist, and also, as you've known, and you could see in front of you, more likely to utilize inpatient care. So for several reasons, possibly because they delay seeking help, inpatient admissions are much more likely to be men versus women. So, think about these things within the context of what I said before with regard to prescription drug abuse, considering the fact that women were more likely to be prescribed antidepressants and specifically anxiolytics and sedative hypnotics and some other drugs that may be prone to abuse. It used to be the case that women were more likely to abuse those drugs. But again, trends have changed in that direction for sure, or in that area. For sure. Men are more likely than women to disclose problems with alcohol use to their healthcare provider. So it may be that we have a situation in which depression may be overdiagnosed, whereas alcohol and substance abuse may be underdiagnosed, under recognized for women. And gender stereotypes regarding proneness to emotional problems in women and alcohol problems in men may constrain help-seeking behaviors, along those stereotypical lines, like I said. There may be a barrier to accurate identification and treatment of psychological disorders. And in this way, I think we can be also agents of change, as I mentioned before, having a simple 2-question screener for domestic violence or sexual violence may be useful in integrated healthcare settings or primary care settings. Likewise, having something as simple as a PHQ-2 in use in a healthcare setting may also be helpful in the identification of depressive disorders in men, and potentially something like the Audit C in the identification of alcohol disorders in women. Who may be, again, less likely, less prone to bring those issues up of their own accord, or self-report. It is, I think it's important also to note that despite these differences that we do see in people who are diagnosed and that disclose and are diagnosed, the majority of men and women who experience emotional distress or psychological disorders are neither identified nor treated. Only by some estimates, only 2 in 5 people who experience a mood or anxiety or substance use disorder are currently seeking assistance in the year of the, or seek assistance in the year in which the onset of the disorder takes place. So once again, I'll highlight that, not because it's something you're going to be tested on, but because it's important to recognize that only 2 in every 5 people who experience a mood, anxiety, or substance use disorder will seek assistance for that disorder in the year in which it first occurs. All right. Okay, let's talk about some facts. Again, this is all coming out of the same report, so additional background to kind of frame the discussion or the conversation that we have. Unipolar depression, and that is major depressive disorder or persistent depressive disorder, is predicted to be the 2nd leading cause of global disability burden by 2020. This was out of the report in 2010, so we will see. As I mentioned before, it's twice as common in women. Not only is it the most common mental health problem, but maybe more persistent in women than men. And more research is needed in this area. The course of depression, you notice I didn't share with you as being different in men versus women. And the reason for that is because it really hasn't been that well studied. even though, as I said, the numbers are much higher. An estimated 80% of 50 million people affected by violent conflicts. So this is not interpersonal violence. This is civil wars, disasters, displacement, um, uh, terrorism, et cetera, are women and children. So not 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 a not a small number by any means, by any stretch of the imagination. Lifetime prevalence rate of violence against women, once again, pretty high, anywhere from 16% to 50%. Both of those measures are probably inaccurate in that there's a great deal of barriers to self-report, and prevalence rates vary across cultures and across um, areas of the globe as well. At least 1 in 5 women suffer rape or attempted rape in their lifetime. We talked a little bit about that before. Alcohol dependence is more than twice as high in men than women. We talked about that. In developed countries, approximately 1 in 5 men and 1 in 12 women develop alcohol dependence during their lives, or alcohol use disorder, as it is now known through since DSM-5. Men are also more than 3 times more likely to be diagnosed with antisocial personality disorder than women. And although there are no gender differences in the rates of severe mental illnesses like schizophrenia and bipolar, we already talked about the fact that their course does appear to be different in men versus women. Let's see, gender differences may have been reported in the age of onset of symptoms, frequency of psychotic symptoms, course of disorders, social adjustment, and long-term outcome. This is really more of what I had mentioned before. Okay. There are some protective factors that I think are important to consider. And what I want you to think about in the context, of this conversation is how many of this, or how few perhaps of these, are actually applicable to women's lives across the world. So main factors that are associated with protection from psychiatric or psychological distress are having sufficient autonomy to exercise control in response to severe events, having access to material resources that allow the possibility of making choices in the face of adverse events, and psychological support from family, friends, or health providers. All those three, once again, from the perspective of how much or how little they may be available to women, depending on their sociocultural status, on the geographical and political realities that they live in, may be significantly unprotective, for lack of a better word, may actually be contributing to, long-term disability and long-term distress being higher for women than it is for men. So I feel like I'm kind of beating on the dead horse, but I just wanted to make sure to highlight why it is important that we have this course, why it's important that we talk about these topics, and that is because women and men are going to be differentially affected by the environmental and social structures of their lives in the worlds they live in. So with that, we're going to move ahead to the next poll, and I'm just going to go ahead and I think I can, oh, okay, there you go. Thank you, Hayden. So the next poll question, I'll give you a couple minutes to review and answer. And we'll go ahead and post it in the, Aiden, if you could go ahead and post it in the chat, just in case there are folks who can't see it. All right, I think we have most folks, 85% responding. I'm just going to give anybody else a few more seconds and we will end the poll. Okay. So let's share the results with the question being, according to the World Health Organization, women are the largest single group of people affected by which disorder related to the high prevalence of sexual violence perpetrated against, I think, against them is part of the question. And the correct answer, which most of you identified, is C, or post-traumatic stress disorder, 87%. It is true some of you identify major depressive disorder and is more prevalent in women. The problem is that we're talking about specifically the association of the disorder with the violence, the perpetration of sexual violence that is a precondition to the development of the disorder. So once again, C, post-traumatic stress disorder is the correct answer. And thank you for participating in the poll. I see in the chat box, Eddie has a question about whether they're going to have the questions available to study.
Yes, Doctor, I will post it after the class, the question and answer. And with your permission, I also right now will just launch the attendance for the morning class.
Sounds good. Thank you.
I will close the attendance in a few more seconds.
Okay, excellent. Thank you. All right. Okay. Let's go ahead and continue. Like I said, we're going to move on to the topic of female hormones and hormonal issues and briefly cover some of the main hormonal agents that you should be aware of. And then in their, in later slides this afternoon, talk about their impact on things like menstruation, birth control, pregnancy, breastfeeding, infertility, menopause, and female sexual dysfunction. So this is a pretty broad topic. Again, lots of information to cover. I will try as best as possible to highlight what's important and what's good to know, but not necessarily critical in terms of your preparation for the exam. And again, just want to re-emphasize that everything in the all of the material I believe is important. Otherwise, I wouldn't have put it in the slides, but it could be thought of as reference material that you could use for your consultative practice or for your future practice as a prescriber. Okay, so pretty self-explanatory. We're going to start talking about the function of female hormones. As everybody knows, hormones are critical in the development of secondary sex characteristics. Primary sex characteristics, as a reminder, are those who are present at birth. So that would be the vulva and vagina and internal sex organs for women, the penis, the testicles, and other, other areas of reproductive function for boys. For both men and women, development of secondary sex characteristics happens at puberty with the development of breast tissue for women, pubic and underarm hair, and whitening of the hips, et cetera, and those are the things that are a direct result of the function of female hormones. They also help in the control of ovulatory and menstrual cycle, or the fertility cycle. Just remember that menstrual and fertility cycle are the same thing. And the control of pregnancy, the control and maintenance of pregnancy, as well as the modulation of several metabolic processes, which we will talk about. So we'll start talking about estrogen, the most commonly known, the most prevalent, and also the most important of the female hormones, which has several different roles. During puberty, it stimulates breast development, like I mentioned before, and causes the vagina and the rest of the female reproductive systems to mature. And by maturation, it's important to point out that we mean to develop to the point where a woman or a girl essentially can sustain reproduction, meaning they can carry a pregnancy and have a baby. It plays a role, excuse me, plays a role in the growth spurt and alters the distribution of fat on a girl's body. I already talked about the widening of the hips, and a distribution of fat around the middle of the woman's body and around the breast. Rising and falling levels of estrogen occur during the menstrual cycle, and I give you a picture that can help you understand and understand and conceptualize that a little bit better. Sustained levels that are stimulated by ACG maintain pregnancy, sustained levels of estrogen, that is. And throughout a woman's life, they help, estrogen helps to protect the heart and bones, as well as maintain the breast and other reproductive organs in what they're referred to as their youthful state. So you can imagine that menopause and the significant decrease in estrogen that happens, estrogen levels that happens after menopause, has impact on some of the functions of the reproductive organs. Okay, it also has a role in progression of some tumors. It increases water and sodium retention. So remember before I talked about water elimination and water retention, those are the direct effect of hormonal rises and falls, or peaks and valleys, however you want to call them, highs and lows during the menstrual cycle, and could potentially have an effect again on medication absorption, especially those medications that are metabolized by the kidneys. It decreases bowel motility, aids in the maintenance of bone mass. Again, another concern that is present in women after menopause is significant loss of bone mass, leading to things like, I'm blanking out right now. I don't know why. I think you know what I'm talking about. Stimulates hepatic production of sex hormone binding globulin, thyroid binding globulin, blood clotting factors, and HDL, and inhibits LDL formation. And this is the reason why women tend to have a better clinical picture or tend to have a lower frequency of hyperlipidemia or high cholesterol, especially premenopausal women, and are much more likely to have a presence incidence of hyperlipidemia after menopause. Osteoporosis, that's what I was thinking about before. Sorry, sometimes I have a moment here or there. So with regards to bone loss or bone damage, osteoporosis is a significant concern for postmenopausal women because of the effects of estrogen on bone mass. We're going to move on to talk about progesterone, probably the second most important, and these are not necessarily organized that way, but I think, in terms of what most commonly known and most important in some of those factors that we're going to talk about, that we are talking about here. Progesterone seems to be the second most important. Along with the estrogen, as you can see in front of you, causes the lining of the uterus to thicken, increases the volume of blood circulating, and relaxes the muscles of the uterus sufficiently to make room for the growing baby. So critical hormone when it comes to the ability of a woman to implant or to have an egg, a fertilized egg implanted and developed into a fetus, and in order to be able to carry out a pregnancy, a full, to full term and birth. Concentrations also rise rapidly during the menstrual cycle. Specifically, they rise in the luteal phase, which we're going to talk about later, and are responsible for increased basal body temperature. So if you've heard anything from any of your patients or from your previous training with regards to the use of natural rhythm for conception, or rather for birth control, basal body temperature is an indicator that the woman may be ovulating. An increase in basal body temperature may be an indicator that the woman may be ovulating in a ways that allows couples who use this birth control method to prevent pregnancy by either abstaining from sex during that time or using a barrier or some other method. Aids in the maintenance of pregnancy, as I mentioned before. It inhibits uterine contractions and therefore, again, facilitates the ability to maintain a pregnancy to full term. May decrease HDL and increase LDL cholesterol, so it has a bit of a opposite effect of estrogen with regards to cholesterol. And increases sodium and water elimination. So once again, if you look back at the previous slide, number 70, estrogen increases water and sodium retention. Estrogen increases sodium and water elimination. And again, you'll see the different peaks and valleys or highs and lows in the menstrual cycle, likely corresponding to women's reports that they're, either going to the bathroom all the time or that they are retaining water and feel bloated and may have difficulty with urination. There are several other hormones that are important for you and for folks to know about. The luteinizing hormone, or LH, controls the production of sex hormones by the ovaries, and an acute rise of LH called the LH surge triggers ovulation. So this is a hormone that is critical for conception and measured for folks, specifically women who are having trouble potentially with getting pregnant or with trouble with fertility. The follicle stimulating hormone, or FSH, controls the development of eggs by the ovaries. It regulates the development, growth, pubertal maturation, and reproductive processes of the human body. So with estrogen and progesterone also helps in the maturation of the reproductive systems. And again, it varies across the menstrual cycle. Testosterone, as you probably already know, is also present in women's functioning. It helps to promote muscle and bone growth, and it's important in the modulation of libido, or sexual interest. Although, its role is somewhat controversial. And when we talk about sexual disorders, especially disorders of sexual interest, you will see that high levels of testosterone in women don't necessarily correlate with higher levels of sexual interest. Okay, and then there's human chorionic gonadotropin, or HCG, little h, capital CG, which is produced by the baby's placenta. It is a hormone, but it's produced by the baby's placenta, and its role is to prevent the disintegration of the corpus luteum, which is the follicle, the ovum, which develops into a follicle, which later develops into a fetus. and thereby maintaining progesterone production that is critical for pregnancy in humans. So this is a pregnancy hormone, and so far as we can have blood levels be an indicator whether a woman is pregnant or not, a pregnancy test that is drawn from human blood would be measuring the level of HCG in the woman's blood, in the woman's body. A normal pregnancy would be expected to contribute to rising levels of HCG throughout, day by day. A pregnancy that may be at the risk of failing may present with high levels of HCG that are later declining or subsequently declining in future measurements. May also have additional functions. For instance, it is thought that HCG affects the immune tolerance of the pregnancy, but less is known about those things. And then we have a couple more that I think are important for us to highlight. Some of you are probably aware of oxytocin, and it's which is commonly known as a love hormone. Because of its role in helping both with the breastfeeding, stimulation of the nipples and facilitating birth and breastfeeding, and in some ways bonding between mother and child, but it also has a role in other behaviors, including orgasm, social recognition, bonding, anxiety, and other maternal behaviors. So therefore, it's a common name of love hormone. And then finally, we'll talk about prolactin. Stimulates, the role of prolactin is to stimulate the mammary glands to produce milk, so to aid in breastfeeding or lactation. Increasing concentrations of this hormone during pregnancy cause the enlargement of the breast or the mammal glands, which present as enlarged breast, and the preparation for the production of milk. And as you know, there are several medications that affect prolactin levels, most of them in the neuroleptic category or the antipsychotic, especially the first generation antipsychotic class. And so it is important for pharmacopsychologists to be aware of prolactin levels, because once again, prolactin has a very distinct purpose. And so any production of prolactin outside of the context of pregnancy are suspect for potentially drug adverse effects. So with that, I realize we only have a few minutes before the break. So I believe we have one more poll question before we break, but I wanted to give you a pictorial representation, and I don't know how well you could see this, but what's important to take away from this slide is the relative presence of the different hormones, the primary hormones during the menstrual cycle. So in general, for education purposes, a menstrual cycle is considered to be somewhere between 28 and 30 days for the average woman. And as you know, average is never average, but again, for educational purposes, what you have in front of you is a 29 day cycle in which estrogen is relatively low in the beginning of the cycle, surges around day 13, 14, which is exactly the midway point of the menstrual cycle. And by the way, day number 1 is the first day of menses. So day number 1 of the menstrual cycle is the first day that a woman gets her period, or the first day of bleeding. So as you could see, about 2 weeks into it, we have the estrogen surge, followed by the rapid fall, and then varying levels across the second part of the cycle, meaning the last 2 weeks of the cycle, which would be considered the premenstrual part of the cycle. In contrast, you see progesterone, which is a brown, reddish brown line, hardly present in the first 2 weeks of the cycle, surges significantly right at the middle point or right after the middle point in day 15 through about 24, and then it falls rapidly. If there's no conception or implantation to allow for menstruation to happen. In the lower bottom of the screen, what you're seeing is the luteinizing hormone, which we mentioned before. Again, we talked about the LH surge being responsible for ovulation, and also you could see that demonstrated in the picture as a pretty significant high, which happens around day 14, followed by a pretty significant drop a few days after ovulation happens. And likewise, the follicle stimulating hormone has fluctuating levels with a surge that also happens in the middle of the cycle. So this is where the biggest takeaway, and again, nothing you have to memorize, is what is considered to be the luteal phase versus the non-luteal phase of menstruation. So the luteal phase relates to the day 14 and on of the menstrual cycle. And we'll talk more about that in the next well, when we return for lunch, when we talk about the menstruation at length. But like I said, I just wanted to highlight the differences or the different surges in hormones during the menstrual cycle. With that, let's go ahead and pose the last poll that we're going to talk about during this morning session. And then we'll pick up on slide 78 when we return. All right, I'm going to close the poll. So just giving everybody or anybody who's hanging out their last chance to post their answer. And with that, with 20 or 77% of you responding, 86% of those responders picked the right answer, which is A, testosterone. The question being important hormones associated with the female menstrual cycle include all of the following except. So testosterone is much more likely to be responsible or much more associated with bone and muscle growth and strength, and sexual interest or libido, as I mentioned before, and not as much, and actually not at all, affecting the menstrual cycle. So those of you who answer A are correct, and for the others, just bear that in mind as you continue your discussion or your study about this subject. Okay, so like I said, we're going to pick up on slide 78, which is the beginning of our chat about menstruation. Not the beginning, we've already talked about it a bit, but we'll talk about problems and issues associated with menstruation when we come back from lunch, which should be exactly an hour from now. So my time is 3:01, your time in the in Pacific is 12:01, and I'll see you back in an hour. I will hang out. I'll close the microphone and the video, but I can hang out leave the chat open for a few minutes in case anybody has individual questions. But if not, enjoy your lunch, and I'll see you in an hour.